evening, everyone. So for this final session, I'll be presenting two cases of ocular oncology. First case is that of a retinoblastoma. So this was a 3-year-old girl child who came to us with a history of white reflex in her right eye for past 7 months. On slit lamp examination, we could see a whitish mass that was there behind the lens with a total retinal detachment. There was intrinsic vascularity within the tumor as well as feeder vessels present. A B scan was done for the child and it revealed an isoechoic mass lesion filling the entire vitreous cavity, and there was no calcification. So although there was no calcification, with the clinical picture that we saw, a diagnosis of right eye retinoblastoma was made, and we screened her parents as well as siblings, and there was no evidence of tumor in any of them. We took the child for examination under anesthesia with right eye enucleation with implant along with bone marrow and CSF analysis. On histopathology, we found that there were no high-risk features for her, and the bone marrow and CSF showed no atypical cells. The child is doing well 6 weeks post-operatively with a prosthetic eye. So a little bit about cavitatory RB and why we are talking about it. Cavitatory change in the size of the tumor or the calcification within the tumor, which are the usual signs that are seen for control of tumor growth. So these tumors do not show much change in the size or calcification, but despite that, they are inactive with they get inactive with chemotherapy and rarely show tumor recurrence. So to summarize, one must be aware of this entity and its better prognostic value. We should also be aware that there will be limited response to IV or intraarterial chemotherapy, and a regular follow-up should be done to look for recurrence. Over to panel discussion.
Thank you, Komal, for this presentation. I would like to ask Dr. Banawali about the change in the spectrum over the last 30-35 years that you've seen at Tata Memorial Hospital in the presentation as well as management of retinoblastoma.
Yeah, unfortunately at Tata we have disease management groups now. So though I used to treat retinoblastomas, now they have put me in leukemia, this thing, so I cannot treat retinoblastomas. So last 10-12 years Nandan and the group has been treating. But overall, just one fact which I wanted to say when the presentation of retinoblastoma has been done was, very interestingly, retinoblastoma is a condition which is very common in countries which have the highest incidence of cervical cancer also. So we had published this some time back, like, in India, we are the world capital of retinoblastomas. That's what we have ill fame of that. So we have, and as you know, we have a lot of cervical cancer also. Also the African countries and all where there is increased incidence of cervical cancer, the retinoblastoma is also common. And we had shown that there is involvement of the HPV virus in the development of non-hereditary retinoblastoma. And very interestingly, in USA where the studies were done, they had no HPV as compared to where we had done around 80% of our non-hereditary retinoblastomas had HPV, this thing. So it's a very important finding, because now that we are treating, giving the vaccination, I think this HPV vaccination may be one vaccine which will be able to tackle both pediatric and adult cancer together, and we are waiting to see how it will affect the incidence of retinoblastoma over the years. It may take many years because we have just started the vaccination, but that's one point which I'd like to make. But other than that, intracavitary, at least when I used to treat, I've never seen this thing. So whether this is a new entity, and maybe Nandan will be a better person to tell if we have seen recently, but at least we have know this thing during that time.
So sometimes we do see retinoblast lesions which are more differentiated, having this cystic appearance, and as your discussion pointed that these lesions tend to respond more subtly, but you need to treat them with the appropriate line of treatment which you decide as per the group, and also apply focal therapy and try to achieve as much regression as you can.
Thank you, Dr. Nandan.
Akriti, I just wanted to add that we have one follow-up which is about 10 years old, and way back when I just started in Hinduja, and over 10 years now. So that patient came, but had very subtle changes of cysts. And of course, we had put a differential of maybe a retinoma also, but we did give 3 intravitreal chemos, and we found very subtle changes, and with focal therapy, so we actually enucleated and turned out to be a cavity, and we only got that when we sent it to LVP for a secondary HP report. So the thing is that the changes are very subtle, yes, but it's not necessary that you have to enucleate also. You may also observe this patient. And just Komal had a question, if this patient was our patient was group D, so would you consider not enucleating if there is not much changes and it's stable?
No, if it is stable, for group D RBs, I would definitely start IV chemo first and see how it responds. If it is responding well, then I don't think there's a need for enucleation.
And then I had one question to Swati and Nandan, that if you're doing in this, if there's between IAC and this, what would you choose? Because both don't have much, they have very, like he said, very low responses and no changes. What would you choose if you had to give between the two for a suspected cavitary?
Do you want to go first?
So at our center, for unilateral group D, we tend to prefer intraarterial chemotherapy for the benefits such as there is less exposure of the body to these high dose chemotherapeutic agents, which in the long term might have ill effects. And the recovery is much faster. In 2 or even 3 sessions, you can actually end the treatment and keep the patient on a follow-up. So that is what we would prefer at Tata Memorial.
Yes.
Yeah, Sabri, I think as we all understand the management of retinoblastoma, it depends not just on the grouping but many other factors that we have to look into. But if all other factors are negated and we are just looking at just a group D unilateral tumor, definitely if the parents are willing to go ahead with intraarterial, that would be my first choice as well. But the way we counsel the parents, I think it depends on multiple factors really. If it is a group DI, a very young child, when I say young child, less than 1 year old, I would still give intravenous chemotherapy. But if it is like this age, 4 or 5 years, and a unilateral group DI, and the parents are affordable to go for IAC, I would counsel more towards IAC. So it depends on really a lot of factors when we counsel these patients.
My question was for a cavitatory RB. Out of that, which one would you prefer?
I wouldn't think that they would respond differently, irrespective of whether it is intravenous or intraarterial, though we have, meta-analysis that has been done by one of the Chinese group on all retinoblastoma, not specifically cavitary RB. They have shown marginal benefit with intraarterial chemotherapy for advanced eyes when compared to that of intravenous, but that is overall, not for cavitary. But I would say that it really doesn't matter whether it is intravenous or intraarterial with respect to how the tumor would respond. I just had one comment for Komal. I think it would have been very interesting to show the histopathology if those were really the cavities, what was the lining, because only on, I agree and I understand that by imaging it looked like, but I think the confirmatory would have been histopathology to see if they were really the cavities.
Actually, so I would like to ask, as you said, there is an association with CA cervix and retinoblastoma. Are we doing P16 for retinoblastoma, and catering means in oropharynx, P positive and negative? Are we looking at or working in those direction?
Again, this is on the research setting. We did that. This treatment doesn't change, but what we had done that time is those patients who had failed all the lines of treatment and still had residual disease, we treated them as per CA cervix type of thing, and they are doing well years afterwards. So it's still in the research phase, but definitely in the future, because you have to understand the difference is that if you say that the HPV is involved, it's the epigenetic change. That means the retinoblastoma gene is intact. It's the epigenetic change that is making the tumor. So now you have something more to look at and treat, the epigenetic, target epigenetic this thing, then you may resolve the tumor. So it's a very interesting thing, but at present it's in the research stage. Unfortunately, we published that, then I left and went to leukemia, and people have not taken it further, but it needs to be looked into.
Dr. Shetty, I had a question for you. So do you do CSF analysis for all group D or group E patients? And if not, what are your criteria for CSF analysis?
So CSF analysis we do not do routinely for intraocular retinoblastomas. We do it for all extraocular retinoblastomas. There are certain select cases intraocular where you have the tumor overlying the optic nerve, or you have a tumor in contact with the optic nerve, which you can see during your EUS, in which case you will certainly do. Having said that, the yield in a CSF analysis has been typically very low. But as you asked the question, you do it only for those extraocular routinely. Okay. There is no point in doing it for all intraoculars.
Thank you. Dr. Sujata, I had a question for you as well. These retinoblastoma children frequently require examination under anesthesia. So do these children show any adverse effects over the period of time?
So this is the most common question that we encounter as an anesthetist, especially from the parents of the pediatric population. So to answer this, yes, it is absolutely safe to administer anesthesia, and repeated exposure is also safe even for children less than 3 years of age. And this statement of mine is backed up with a lot of literature which proves that there's no long-term side effects or cognitive dysfunction which has been seen in such children. So yes, it's safe.
Thank you.
Thank you, Dr. Sujata. For one last question to Dr. Swati, what would be the signs of regression in cavitary retinoblastoma that you would ask everyone to be on the lookout?
Yeah, thanks, Akruti. I think as Komal has already shown, these patients with cavitary RBs do not regress as much. The size reduction is not as much as non-cavitary RBs. But the signs that we have to look out for is obviously if there is any change in the size, if there is any new onset retinal detachment or the subretinal fluid that is developing, or the subtle seeds that might appear at the margin of the tumor. So these all can be the signs of activity. So I think it's very, very important in these cases to document with fundus photographs so that we can compare each time and identify even the slightest of size change that can occur.
Thank you, Dr. Swati. So my second case is of an orbital tumor. This was a 30-year-old lady who came to us with complaints of painless mass, medial to medial canthus, and watering since 6 months. So she had already undergone DCR in December 2023 elsewhere, followed by DCT in January 2024. Her DCT sample was sent for histopathological examination, and a report was available which said that it was a lymphoproliferative lesion. So she came to us with this recurrent lesion, which was painless form mass at the sac area with overlying skin induration. There were also surgical marks from the previous surgeries. We ordered a CT scan for the patient, which showed an isodense lesion involving the paranasal sinuses and also the medial orbit. It was difficult to comment on bone erosion as DCR was already performed for this patient. So at this point, our differential diagnosis were lymphoproliferative disease, as she already had a histopathology suggesting that, squamous cell carcinoma arising from the sinuses, sarcoma or metastasis. So our plan here was to debulk the lesion externally as well as endoscopically and do a bone marrow biopsy for her. So we went ahead via the skin incision and debulked as much of the lesion as possible through the external approach. And then we also did a nasal endoscopy which showed that the nasal mucosa was intact but it was thickened. So we debulked the lesion via endoscopic approach as well. So here the histopathology showed darkly stained nuclei with scanty cytoplasm. It was myeloperoxidase positive. On IHC it was CD34, vimentin and BCL2 positive. The bone marrow was hypocellular and the myeloid series showed sequential maturation and differentiation. The peripheral blood smear of the patient showed 41% blast cells, which are basically our immature WBCs. So with this scenario, a diagnosis of myeloid sarcoma with AML was made for her. The patient is currently undergoing chemoradiation at Tata Memorial Hospital. So to just briefly summarize about myeloid sarcoma, it is an extramedullary solid tumor which is caused due to abnormal proliferation of immature precursors of WBC. It is also known as chloroma due to the greenish hue it has due to intracellular myeloperoxidase enzyme. The other synonyms for this disease are granulocytic sarcoma, myeloblastoma, myelocytoma and chloroleukemia. But the current terminology which is accepted is myeloid sarcoma. It is mostly seen in children, and 88% patients present with orbital involvement before systemic diagnosis is made. As for the review of literature, there is only one more case report with an myeloid sarcoma which presented as an NLDO obstruction, and the patient did well after local radiation as well as systemic chemotherapy. So to summarize, systemic investigations are very important in these patients. Bone marrow biopsy and peripheral blood smear should be performed. Treatment consists of local treatment with debulking and radiation along with systemic chemotherapy. And the 5-year survival rate for these patients is around 29%. Thank you.
Thank you, Komal. I would like to ask Dr. Savri. Oh, sorry, sir. Yeah.
No, it was written as initial also as lymphoproliferative. The sarcoma and all doesn't come in the differential then, and the surgery doesn't come, because lymphoproliferative is usually either lymphoma or, which is very, very rare, or, again, myeloid sarcoma is it's a misnomer and it's no longer used. It's called now extramedullary myeloid tumor. So the sarcoma is a misnomer and it is no longer used now, that terminology. So extramedullary myeloid tumor is what we call it now. So maybe if you put that, you may see more cases also. The sarcoma is no longer used and will not have operated. This is ideally, though it's a local thing, like you showed, most of this is be considered as a systemic disease. So even if there is no bone marrow involved, we treat them as per acute myeloid leukemia only, and they give systemic therapy is given in this thing. Radiation therapy, there is no, basically this thing, but there is no study also to show. But, maybe one study, which was a randomized study, they started with radiation, but the recruitment took so long. This is in children in USA. That time there was COG and POG. There were 2 groups there, and they couldn't finish the recruitment and they stopped in between. But at least till that time it had shown, though p-value is not significant because the number of patients were not completed. But there may be a role of radiation therapy definitely that needs to be looked into. But systemic therapy is definitely a must. Surgery I won't do if it is a...
So the idea of intervention again in this patient was because we didn't have immunohistochemistry and we were not sure about where the histopathology was done, as both the DCR and biopsy was done elsewhere. So we just wanted to confirm, that's why we debulked as much as possible.
It's easy to tell post this thing, it depends on what. But if I had got the first specimen, looked at it and it was lymphoproliferative, looked into like the MPO stain and all, found it to be myeloid tumor, I will not have done the surgery.
We had asked for the slides and blocks from the patient, but they did not have anything.
No, sir.
No,
it was
no,
done in UP. She had operated elsewhere. That's why we intervened. Because you feel, why did we intervene in her? That's why I'm telling you why.
So regarding the role of radiation, I agree with you. There is very limited. There are some retrospective series which have shown some PFS benefit, but definitely no OS benefit. Local therapy may be used, but the main, as you said, it has to be considered as AML and treated on those lines.
So, Dr. Savri, I wanted to ask, how often do you come across lacrimal sac tumors or masses which have been operated for DCRs? Because this is something
so
like
in the last 16, 17, in orbital lesions, this is anyway very less, and our sort of thing matches that. It's very less. It's a very small percentage. Strangely, in the last 6 months, we've had a spurt of 3 cases where the DCR has been done, but the oculoplastic surgeon has had the insight, found something odd and sent the biopsy there and then. So one was an adenocarcinoma and one was a rhabdomyosarcoma. So luckily we got diagnosis on both, and patient has been treated. What I would say is that anything that looks a little unusual, and I have fallen, almost succumbed to this in the past, that looked like a mucosal. something, just nagged us. So we, instead of just doing the DCR, I did send for imaging. And CT scan is, of course, the imaging of choice to see, the sac, the NLD dilatation. But here with Hinduja, what we do is we do a MRI with a limited CT in the same cost. So we get a little bit of the soft tissue if there is any extension into the, into the nose. Plus also we get soft tissue findings and bone findings. So I would definitely say that that's a point to take home if it's a odd looking swelling. I think this one also had a little swelling going above the medial
Slightly
canthus.
above the medial canthus, yes. So it
Thanks.
was likely to.
Dr. Neerav, I would like to ask you, what advice would you give us young lacrimal surgeons to not miss out on such lacrimal sac tumors?
So that's a very important question, and few of the points Madam has already covered. So one thing is you start from history like we had in this case. If there has been DCR done in the past multiple times and has failed, you try to look for why it has failed so many times. Not always, it could be a tumor, it could be a tubercular infection or something, but you definitely want to look into why there are multiple failures. Other point probably which on history you can pick up is a hemolacria or bloody tears. So that should ring a bell and you should try to look for a tumor there. On examination, like ma'am said, any mass which is going above the medial canthal tendon is obviously a red sign or a red flag. Another thing in terms of the medial canthus that you can look at is displacement of the canthus laterally. So anything that you see, look at the patient and you feel that the canthus is compared to the other side, it's more lateral. Again, you try to look for a mass and send the patient for imaging. Also on palpation, normally like a mucocele would be more cystic or fluctuant in feeling, whereas a mass would be firm or a tense mass. So palpation also can give you an idea. So these are the few things you can look at clinically. And obviously on table too, like I think Dr. Savri mentioned that an oculoplastic surgeon can pick up anything abnormal you feel, you should send a part of the sac wall for histopathology.
Thank you.